Okay, so it's 4:30. We're gonna get going. Uh, this may or may not be the very last HiPAM community work group. So I'm not sure if everybody in attendance received the emails that Victoria sent yesterday. Huge congratulations to Monique, the rest of the team for their multiple publications, both modeling and with the policy paper. But unfortunately, our funding is ending end of June, and I think everybody in HiPAM is ready for for a mental health break, and recognizing COVID is going to continue to be here, but hoping that the work that we've accomplished as a group and as a team and a community laid the foundation for our ability to incorporate the work of HiPAM into something more long term, and that's something we're working on right now. So HiPAM currently as is will cease operations at the end of June 30th. So that being said, everybody here, and this is recorded, so everybody who's participated in the past years, it's been an honor, and what a journey. So with that, let me share. Okay, so start presentation. So I think everybody here is very familiar, so I'm not going to go too much. Japan yet to open up to Hawaii residents, but talks of maybe potentially, they're definitely way down from where they were at the beginning of the year. We'll see what's going to go on, with all these variants. The subvariants, it's hard to tell, and it's hard to predict the policies of other countries, let alone ours. South Korea, no major spike. Obviously 70 average of 20,000, still a lot, but I think what we have to remember now is testing is not uniform across the world, even across the country. So it's really hard to compare apples to apples, the 70 averages, the cases, especially because of at-home testing and whether or not people are reporting and getting confirmatory PCR tests, etc. India, you saw the three major peaks and nothing right now. So we just like to keep an eye in the Indo-Pacific. For our national overview, so you can see as a country overall, where we are seeing an uptick, but I would like to caveat that at this point it's just so difficult to make any specific conclusions at a national and a state level, just because of the lack of uniformity of testing. I think it's just it's a big limiter to drawing any causal conclusions with regards to what's going on besides an overall trend. Arizona, California, trending upwards. Once again, not hard to keep track of their testing rates, etc. Nevada, Texas, upward trend mirroring the national trend, but once again, what we're keeping an eye on is the hospitalizations, at least locally and across the counties. So, there's a lot of red for Hawaii. One thing to remember is that our metrics that we're getting is not daily anymore. We thank the DOH for working so hard, DocD, for putting out daily reports, and recognize that they also have to shift priorities, and there's funding issues as well. So, we're also working with once a week updates on percent positivity and cases per 100,000. So it's really hard to get anything granular. And then, focusing on Hawaii specifically, with limited, with the shutdown operationally of a lot of drive-through testing and PCR testing, and also a lot of people shifting to at-home testing, and it's very hard to get a good sense of the proportion of people who take that at-home test and get a confirmatory test. And then also just human behavior is incredibly difficult, especially now since that there seems to be a consensus of behavior across not just the state, but I think nationally, in terms of just COVID fatigue, and people who may, even if they're vaccinated or unvaccinated, just get symptoms, just not even test. So in terms of cases, most likely an underreport. But once again, at this point, given our vaccinations, given the fact we have vaccinations and much better treatment and better understanding of disease pathology and kind of the timeliness of when to intervene with these new treatments, the big factor is now the impact on hospitalizations with these subvariants, and also, the impact to the at-risk, the high risk populations, the elderly, the immunocompromised. I think at this point, that's really where the focus should be, and it's, at this point we are still working on getting that granularity of data. So Hawaii continues to be great at least one dose, and completed primary series 77% higher than national average. With first booster, second booster, at this point the science is showing that it's really dependent on your risk tolerance and also your individual health outcomes. If you're immunocompromised, elderly, both, or have other adverse health outcomes, it's probably better to get boosted. But if you're healthy and are younger, the protection conferred by the two-dose series is still sufficient against severe death and hospitalization. So it's really hard to make sense of this at a macro perspective. So this is our 2-week forecast. Monique's going to spend more time speaking more in depth about it, but once again, I'm going to talk about this as when we get to our policy paper, but really just focusing on the trends, especially given the limitation of the current data that just we have access to that's publicly available. So in terms of real data, yes, hospitalizations are going up, but once again, that's only up until last week. We're waiting for up-to-date data, and in terms of cases, we just saw, I think, 7,000 over the past week, but it's hard to get the day-to-day fluctuations and also for the specific counties as well. So trending slightly upward, but once again, in terms of hospitalizations and ICUs, no current concerns. So, I think it's fitting. We've been together for a long time. Monique's been great. We've had Tom, Lee, Yosh, James. Jim has been here from the very beginning as a community partner. And I think it's just fitting that the first two science highlights we're going to focus on, is really a validation and culmination of the work that we've done locally, and that's been peer reviewed and recognized at a national and international scale. So we want to focus on those two, and then also recognizing that there are secondary and tertiary impact continuing from COVID as we transition to an endemic phase. What are some of the big issues besides cases, hospitalization, et cetera? And I wanted to focus on long COVID because we from a public health perspective, there's still a lot we don't know about the long-term impacts, and how do we figure out and have early detections on those. So I wanted to call out that particular article. So I remember writing the first draft of this paper in July of 2020, because it was already clear that there was a need to educate and to share the utility of modeling for both education and for policy making purposes. And for those in attendance, if you're at all aware of the rigor and just the lack of timeliness of publications, it's fitting that it took almost 2 years to get this paper published. And all our co-authors are listed here, but we definitely acknowledge all the participants of HiPAM and those within the state who supported all of our efforts, and really culminating in this paper that presents a case study of how modeling was utilized in Hawaii and some lessons learned. And there's some technical, yes, Ember. There's some technical portions of the paper that highlight the 4 models and inform the early work before we were fortunate enough to have Dr. Shiba come in and really take it to the next level when we had more time and shifted from an emergency response to a more long-lasting response. But just want to highlight a couple lessons that, to this group, I'm sure is common sense, but to a lot of people who don't really pay attention to modeling, I think it's useful to note that our modeling really, HiPAM's modeling really benefited from the incorporation of state and county specific data. So really a huge shout out to the role and the work of DOCD and DOH, and they've come a long way in the early days in the emergency response to really standing up a really great dashboard and showing a bunch of different ways to interpret and look at a lot of COVID data. So that really was a big reason why we were so successful in the modeling, at least in making sure it's way specific. And then finally, I think if you listen to us speak in public and in these forums, we harp on it all the time because it's so important that, we're not trying to get the number right. We're not trying to play the prices right, because there's just so many variables, of the biggest of which is human behavior. But the purpose is we can help with the directionality of it and at least be an early detection for policymakers, for those who have the ability to make data informed decisions. So just wanted to highlight those. The link previously here, if you click on that first one, I apologize, I need to update that, Rukia. I will put the link to the paper, but it's also already on our website. It's free, open access. The PDF is there. We'll let Dr. Shiba speak to that later on, but I also want to call out the great work of her and her team, and all of really just tremendously proud of the grad students that have really played a big role in the success of HiPAM and the modeling. But their goal in this paper, I'm not going to read it really out loud, but it was just to look at the differences and similarities of COVID-19 spread across the Hawaiian Islands and between other types of islands, just because, once again, we recognize the uniqueness of geography, culture, in terms of how COVID-19 impacted our state versus, CONUS, continental United States. And so we want to look at if that held true across other island chains. And the results really, should be no surprise that mitigation measures should be targeted to local populace, not even at a state level and county level, if we're really to be to get the most efficacy. And that's something that HiPAM continued to work on throughout the pandemic. And then finally, once again, it seems very common sense, but in terms of academic rigor, we needed to prove that the spread of disease was very sensitive to unexpected events, including, just human behavior and certain changes in mitigation measures. Finally, long COVID, I think, will be with us just as long as we have COVID-19 cases. And there's so much left to learn. And I chose this fittingly because they utilize machine learning modeling to try to get a sense of patterns of symptoms using a retrospective analysis, looking back at thousands of electronic medical records just to get a trend and a sense. And this is just the beginning of huge learning, a long-term learning of what the impacts of long COVID are and how we can learn from those who already have long COVID and better predict the impact. So with that, I'm going to stop sharing and then hand it over to Dr. Shiba.
Hi, thank you, Thomas. So I will go and start sharing the update. So before I go any further, I wanted to highlight a little bit the students as well. We've been working. So what you're going to see today is hot from the oven. Yeah, we just finished it today as a group. So they're still working really hard. We're meeting basically daily to continue working on the model. I'll show what modification have been done on the model, but I wanted to congratulate them. So we have one undergraduate student. She just graduated. She's moving to Rice University in the data science program. One of the other undergraduate students that's been working on the modeling, she also graduated. She's moving to Berkeley University for grad school. She wants to go into the medical field. One of the graduate students received the ARC Scholar Award, the Sarah Ann Martin Award in mathematics, and in part due to the work that he has done on the COVID modeling. The paper that Thomas mentioned, it's a graduate student at the first order. We have a few more papers in the pipeline. We have for next week, two graduate students and one undergraduate student have a poster that have been accepted to the conference that will be here in Hawaii at the Hyatt Regency Waikiki Beach and Hotel. So if you're interested, you can go. It's the new advances in statistics and data science. So the work has been heavily peer reviewed, and it has been very well accepted by the scientific community. So it is, and the students have done an admirable work, and they will continue to do that. I expect a few PhD and master coming out of that work shortly in the next year or two. Okay, so regarding the modeling, now I'm going to go a little bit into that and what's the current situation. So there are more uncertainties than ever right now. So first, Thomas already touched upon that, the testing and reported cases. So it is not completely clear what is the magnitude of people testing at home. Then we have the vaccine fading. It's not neither well quantified. The rate of vaccine fading, when, for what kind of population, the demographic, is it dependent on age, on that kind of information we don't have. Reinfection, it's not clear neither, the quantifier for reinfection. We know people have been reinfected. I know personal cases of people that had COVID and had it again. So it is happening, but the exact rate at which it's happening, the exact time frame at which it's happening, those are all parameters that carry a lot of uncertainty. They have some studies that have been done, but it is really hard to have it based on a specific demographic, on a specific population, etc. So we have those parameters, but they fluctuate. They might fluctuate a lot. So we've had to make some assumption in the model. Then we also the rate of hospitalization due to COVID. This is also a question mark, because the COVID hospitalization number that are reported, they're not necessarily people that are patient due to COVID. So we are personally with the model, we're looking at like hospitalization are for us people that are hospitalized because of COVID that have severe diseases. So it has been increasing. However, the ICU seem under control. That means that they are, because we are on a surge, people that are hospitalization are also on a surge. It doesn't mean that those COVID hospitalization are necessarily severe. A lot of them are not. And then the traveler is also a little bit of a question mark, because the reporting has changed from a daily report back to a monthly report. So we're struggling a little bit to adjust all this. That makes it really hard to do accurate modeling, but nonetheless, the model is still showing the trend very closely to what we see. So as having done the model for 2 years, I don't see anything very surprising happening in Hawaii. The surge is expected. It has been, the model has been showing the surge without a change in the parameters. So we're not fitting the current surge, because the data are not, they might be misleading, and we're very careful about that. We are doing our model based on what we've learned over the last 2 years, and we see that the trend is following very well the data. We are sometimes above, sometimes under, which makes sense in those reasons. So here is a lot of a little bit of a takeaway. We are talking about, I'm going to mention a little thing about the peak. A lot of people are like, when is that current surge going to peak? We are on a surge. That's difficult. Again, it is because vaccine fading. It is because reinfection, they start playing a big role. Now it's an interplay between transmission, people losing efficacy of the vaccine, and people getting reinfected. We had a lot of people that got infected during the first Omicron surge. And those people, about 6 months later, they might be going back into the susceptible. So we're going to, the model is really predicting sort of a wavy behavior, where we're going to go to a surge and then go down and then a surge again, because we're picking up the people that were infected before and that are coming back into the susceptible pool. And with the vaccine, we have to see also how it's going to play around. Hospitalization, as I said, they've been increasing, but it's a consequence of the current surge, etc. So let's go a little bit. So First, we looked a little more carefully at the test positivity. So the test positivity has been increasing on all the counties. So here is to give you a little bit of perspective, yeah, that we have about the test positivity. So the purple bar is when the DOH started, like, stop reporting positivity for about 2 weeks. Otherwise, you can see we are reaching the limit of what the test positivity, the highest test positivity that we had during the first Omicron surge, and we exceeded that on Kauai. So now again, there is the comparison between Omicron. So here what we did is that we realigned the test positivity of the 3 major surge that we had, the Delta, the first surge with Omicron, and the one that we have now. At all 3, they did hit a 5% positivity rate at some point for all the island, and we aligned that together to see how those play together. So the Omicron, the first surge of Omicron, has the steepest ascent in test positivity with respect to the Delta, and now even to the Omicron 2. Only Kauai, the current Omicron 2, is matching the steepness of the test positivity that we had during the first Omicron surge. However, what we are observing right now is that the increase is lasting longer. And this is, again, I do believe, because we are having those vaccine fading and reinfection, and then more people are back into the susceptible pool, and the Omicron 2 is very transmissible, even more so than the Omicron 1 was. So we see that increase. Now it is not clear about, this is the number of tests that have been done, right? This is the total number of tests. So you can see the purple is Omicron 2, is the current one. So you can see that the tests that are being reported are well under, right? So one, like, it is unclear, but one explanation of the high positivity that we might have right now is also possibly the fact that the people that are getting tested now and for whom the tests are reported are because they're going to see a doctor, and that's because they have symptoms, and there the tests are likely to be positive. That might be bumping the test positivity to the up. There is no proof of that fact, but that's something to keep in mind. All right, so now I'm going to the model and see a little bit the update that we've made. So we realigned the model in order to account for the fact that the vaccine might be fading. So you have now an arrow that goes from the vaccinated to the vaccine fading, and this is mimicking the rate at which the vaccines were administered in Hawaii for each county. So we're mimicking that rate, and we're doing, if you want, the symmetric now into the fading. And then the reinfection, as I said before, it is completely unclear the exact period at which someone gets back into the susceptible pool in order to be reinfected. Is it at this, and then is the reinfection at the same rate? But we had to make some executive assumption, and we assumed that reinfection would occur after 6 months of the initial infection. Here's some definitions, and those are important because they differ a little bit from the numbers that the DOH is reporting right now. So we have a discrepancy between those real numbers, between the numbers that are reported from the DOH and our model, but the discrepancy actually makes sense. So, but before I say that, our model, like in April 15, I asked one of the graduate students, I said, oh, can you just like evaluate the percentage of the population that has been infected until like April 15. And he came back and said 57.8%. And I got really scared because it seemed to me to be a really very high number. But like a few days later, the CDC came out and said that they were estimating to 58% of the US population been infected at some point in the past 2.5 years. So that really validated, I think, what the model has been calculating behind the scene, because this is based on all the asymptomatic, on all the numbers that you cannot collect and the data that you cannot have. So that was sort of comforting and gave a little bit more confidence about the model. So total new infection, those are the infection that will be detected if every day we were testing the entire population. So that means all the people that would stay asymptomatic throughout, that would never know that they are having COVID, etc. So that's a much larger number. And as you'll see for Honolulu, for instance, we're estimating that number to be about 8 times higher than the numbers that are being reported, which is not unusual. We had that a big gap before. We are just not providing those numbers. Daily new cases, those are the number that we suspect of people that are testing. So those are not the reported, because for us, those are including the test that people will take at home. So our daily new cases are higher than the one that are reported. Active hospitalization, those numbers for us are individuals that are hospitalized with severe symptoms. So those numbers are smaller than the one that are reported. And then we have total active asymptomatic infection. That means like it's the total number, not the new or that we're just getting infected, is the total number of people that are currently infected that are either asymptomatic or vaccinated. So those are sort of the numbers that you're going to see below. So some parameters, the update will be available on HiPAM. So you can see we had the model in order to understand the model to make it work. It also estimates when the different variants have been introduced. We are working on the new competing variant now, the 2.2, or I'm not sure, but the second Omicron 2. So this is being incorporated right now. Vaccine fading and mask mandate has been removed. Safe access has been removed. Safe travel has been removed, as it has been the case. So here are some numbers for Honolulu. Those are numbers that cannot be measured because you're not testing the entire population every day. You don't know how many people are asymptomatic, but this is something that the model can infer. So if we look at at May 16, and we take our numbers and we bounce those versus what the DOH is reporting. So we are about 8 times higher in total in the number of total new infection, which is the DOH said they're estimated at about 6 times. So this gives maybe a slightly more accurate estimate. And the daily cases, like our estimate of people that are currently getting tested but not necessarily reporting, is about 3 times higher that's been reported. And here you can see that the percentage of infection, now we're talking about infection and not infected individual, because we might have already now reached the point where people are getting reinfected. So in the total number of infection, it might be people that have been infected a few times. So we cannot compute that number anymore as a percentage of the entire population. However, the total number of new infection per day that will stay asymptomatic is decreasing a little bit, and the total new infection on vaccinated individual as well. This is due to the vaccine fading. So here is what we have. And in terms of the peak, so our estimates, but this is extremely delicate to say, and I'm not completely comfortable, but the estimate is right now that in between early June and mid-June, third week of June, that's when we see a peak happening. It depends, the time depends mostly on a county, and the numbers are also based on what we are inferring right now from the current situation. So about 4,000 for Honolulu, which is not that much different than what we have for the first Omicron surge. Then here for the hospitalization, so here you see clearly that the daily cases that are reported, that are the dots, are under what our green fit, which is what we think should be the best fit. And that's because some cases are unreported. For the hospitalization, it is above, again, because our fit is is modeling the hospitalization due to COVID and not patient hospitalized and having COVID. So that's slightly different. The peak is going to be like second half of June to end of June, again, depending on the county. And they are estimated to be lower than what we had for the first Omicron. So here, that was Honolulu, and you can see for Honolulu, about 1.2% of the ICU bed are currently occupied by COVID patient, and 3% of patients on ventilators are COVID patient. Those are small number, a very small percentage, which shows that very likely, and as we can see here, the hospitalization are actually, the severe hospitalization are actually under the numbers that we received. So for Hawaiian County, you see 11 and 7%. This is because those numbers are extremely small, right? If you have 2 people, 1 out of 2 people, it's 50%. So the smaller number of people or patient in hospital, then the higher that percentage is going to be. All right, so here again, you can see those number a little further as we move forward. As you can see those numbers, sorry, I was just looking at the chat at the same time, but you can see those numbers on the HiPAM website later when it's going to be put over there. So let's see, this is Hawaii. Yes, Hawaii daily cases. Again, they are under what we expect, but you can see that the trend is very similar. The slope at which the reported cases goes up is very similar to something in between the green and the blue line. And then those are the hospitalization. It's been increasing a lot the last week. Again, that might just be due because we had an increase. We are on a surge in terms of daily cases. It doesn't mean that the hospitalization are necessarily with severe cases. So we are expecting that surge. It comes with the surge of daily cases that we have. Now, I'm not trying to downplay neither the fact of getting COVID. A lot of people have COVID with mild symptom. It's still very annoying and it's still a big disruption to the life. People might not go to work. They have to isolate. So I think it's like we are on a surge with no question, with high transmission, and people should really be aware of that and take plan their action in terms of that. So Maui County, it's very similar to Hawaii County. Here are some data that you can find from the website. You can see like there is very, because the number has smaller modulation in the numbers is also smaller. You can see the trend here. It's been even the steepness at which the daily cases have been increasing on Maui is lesser than on Hawaii. They are better vaccinated. I don't know, is it correlated or not? Again, the peak right now is projected to happen in June. Here is the hospitalization. In the same vein as for Hawaii County, the Maui hospitalization have seen a surge over the past week. It has to be observed, but the ICU and the ventilation are at a very low usage in Maui County. They are at zero usage right now on Kauai County. Now, I don't know exactly the capability that they have in terms of ICU and ventilator, and if people would be moved to other county, but Kauai County gave us a little bit of a harder time in terms of the number and the modeling. It's been much more erratic because the numbers have been smaller. Kauai had also a relative larger surge from all the county during the first Omicron surge. They had a lot of cases in January relatively to the population size, and therefore it impacts quite differently the future and what we see right now. So those are the daily cases. So again, they're going a little bit up and down, and we've seen a lot over the past week increase in the daily cases, or I would say more 10 days. Again, we don't get the cases every day. So then there was suddenly a big jump in hospitalization. That's unclear. There was, it went from like 4 to 10, and then it sort of stabilized over there. It's unclear what had happened, but again, no ICU and ventilator COVID patient on Kauai. So now I wanted to also highlight something that we've been observing, the flu cases. they are picking up. So this comes with the fact that the mitigation, they've been relaxing. We don't have mask mandate. People are resuming regular life, and therefore the flu is finding a way to go from people to people again and to be transmitting. So you can see the yellow is the flu. You can see for 2021 and 2022, you can see it was basically flat. The orange is the end of the orange curve is the beginning of COVID. So then you can see it was followed by the gray curve. The flu season start like, it is more, it started on week 50 and then typically the week 14. So, but right now, because we had no flu, people are more susceptible to the flu, and we took away a lot of the mitigation. So the flu is starting to pick up. That's something to watch, especially for the most vulnerable population, and consider maybe vaccinating at a different time of the year than doing usually. So that's something that we're going to keep monitoring. That was the vaccine. This is the vaccination rate typical by year in Hawaii. It's very different per county. Honolulu County is much better vaccinated for influenza, for the flu typically than the other county. So you can see that in 2020, more people got vaccinated by the for the flu than it was in 2019. I'm hoping 2021 people did that as well to avoid to have a combination of COVID and the flu, and we'll see what is going to happen this year. So this is what we have for the modeling update as of now. Thank you.
Thank you so much, Monique, and thanks to Jim and Marguerite for participating in the comments. And one thing to keep in mind from an epidemiology perspective is, I think Monique's done and her team has done a great job trying to figure out the vaccine waning efficacy, reinfection, et cetera. But it's still too early to say, what the vaccine regimen is going to look like at a year-to-year basis. We don't have enough data to know. I don't think anybody does, in terms of, are we going to have a yearly COVID season, and then if that's the case, is the pharmaceutical companies going to release yearly COVID shots? We're not at that point, and so unfortunately, to Marguerite's point, when we have good news, we're not sure how long it's going to last, just because the response to COVID, at least from the vaccination perspective, has not become regular or cyclical in nature. So it's just, it's difficult to say. And Jim, thank you for your comments in terms of, looking a little more closely at types of variables that are utilized in Monique's modeling, and a potential impact to that based on the lack of timely information due to operational constraints. So we don't need more work, but we'll gladly look into it, just because we're once again, if this is indeed our last HiPAM meeting for the foreseeable future, I think we would like to end on is what we started, is just here to support the community, help bridge the gap to what COVID's doing, the data points that we do have, and how we can educate both the public and leaders in the space to be able to make good use of the data and the outputs. So thank you again, everybody, for your participation. We'll keep our website up at least until June 30th, and we'll probably archive it so you can have access to all of the great work that our team has done. But please, feel free to use the email to send us any comments, feedback. This isn't, goodbye forever. This is just a pause. I think Monique and Rukia and Kiani and everybody who's been part of the day-to-day operations of HiPAM could definitely use very well-deserved break. So definitely something to look forward to as well. But if there's nothing else, thank you to the 9 of you for your participation. I know a lot of you have just been steadfast and loyal to what we've done, and that's all that thanks and testament we need. Is that the community believes in what our work, and it's been an honor, like Victoria and Monique have said. It's just good things happen when people step up, and everybody has stepped up, and there's always a silver lining in bad things, and the HiPAM definitely was one. And hopefully we can continue the momentum forward in some other ventures. I think it's made apparent that modeling there's a definite use for modeling, not just for pandemics and emergency response, but for to help answer other Hawaii pressing challenges, whether it's in the human services space or health space. So hopefully we can take this momentum and turn it into something bigger and better. But yeah, Monique, go ahead.
Yeah, I just wanted to say that the science is not stopping with HiPAM. Maybe the emergency with the weekly report and using it as a service tool is, but the pandemic highlighted a lot of limitation in terms of the modeling in the data, and this is something that we're going to work really hard. I think that's now mathematicians now that have to work, and it's going to take a good couple of years, I think, to really understand, learn lesson. What the mathematical model have been very good, and I see that right now because you were using like a simpler model, and we get the trend. It's very good at modeling the trend and the different loops that we can have and the interplay between vaccine, etc. What is difficult is the quantifier. It's to model the magnitude of those, and that has been the challenge, and that's related to data accessibility. But the trend, the models are actually pretty good at doing that. So a lot of lessons to be learned, and the students are not going anywhere, neither UH is, and we keep working.
Yeah, thanks, Monique. That definitely well said. With that, it's 5:12. Thank you all for your just continued support of HiPAM, and until we meet again virtually or in person, it's been a pleasure to serve as co-chair of HiPAM for what seems like forever, but it's been not even 2 years. So stay safe, everybody. Keep in touch, and like Monique said, the work will continue. And please visit our website. Yep, go ahead, Monique.
No, I just wanted to send a wave or something and put the raise hand. Just thank you, everybody. That's it, nothing.
Thank you all. Have a great evening, and hopefully I'll be able to run into you at some point with or without a mask. But take care, everybody. Stay safe. Aloha.